All right. Good evening, everyone. My name is Rujar Patel. On behalf of Cipla Critical Care, I extend a very warm welcome to all our esteemed doctors and healthcare professionals. Thank you for taking the time to join us today's academic webinar on antiphospholipid antibody syndrome, past, present, future, state-of-the-art medicine practice guidelines. Antiphospholipid antibody syndrome remains a complex autoimmune disorder, and with evolving evidence and updated practice recommendation, staying abreast of the latest development is essential for the improving patient's outcome. We are privileged to have with us two distinguished experts in this evening. So let me introduce our moderator for today's sessions, Dr. Kundavi Shankar, HOD and a senior consultant at Madras Medical Mission, Chennai, a renowned expert in reproductive medicines and high-risk obstetrics. She serves as a lead fertility consultant at the IRM MMM. She is the honorary secretary of the OGSSI, vice president at TAPI-SAR, a member of the Fertility Preservation Committee of FPSI, and a recipient of the IFS Achiever Award and ISAR Dronacharya Award, with numerous national and international publications and invited faculty engagements. Dr. Kundvi has made a significant contribution to the women's health and reproductive medicines. We are privileged to have her as a moderator for today's session. And ma'am, it's truly honored to have you with us at this evening. Without further ado, I invite Dr. Kundu Shankar to take the session forward. Thank you, ma'am.
Thank you for the nice introduction. And it's my pleasure and my honor to introduce our speaker, Dr. Apollo Hospital, who's going to talk about present and future. Can I have his CV, please?
Ma'am, is it visible?
Yeah. He's a well-known rheumatologist, I think, throughout Tamil Nadu and India. I think every gynecologist depends upon Sir for his advice regarding this antiphospholipid syndrome. Over to you, Dr. Ramakrishnan, sir.
Good evening. Thank you, Dr. Kundavi Shankar, for the very kind words. Today, my lecture is on obstetric antiphospholipid antibody syndrome. Yesterday, today, and tomorrow. The reason why I chose this particular caption was I have literally grown with obstetric antiphospholipid antibody syndrome for the last 35 years, seen it in its infancy, gone through its adolescence, and now when it has become an adult, it has been so gratifying for me that the journey has been extremely rewarding and rewarding to me as far as patients with APS are concerned. At present, I'm a senior consultant rheumatologist in Apollo Medical Center, Chennai, Anna Nagar. And we'll go with the first slide, please. Are the slides seen?
Just minimize the browser, sir. Open the presentation. We can see the browser, sir. Just minimize the browser. Or stop your share screen, share again. Select the entire screen, then click on the share button. Click on the share, select the entire screen, then click on the share. Yes, visible.
Yes,
Slideshow, please. Full screen. Yes, sir. Go ahead.
The talk today is on obstetric antiphospholipid antibody syndrome, affectionately christened as OAPS for the day. What is my present agenda? Why APS matters in obstetric practice? As obstetricians, definitely patients with recurrent pregnancy loss. An antiphospholipid antibody syndrome occurs for a great percentage of recurrent pregnancy loss, which is treatable. Yesterday was historical milestones and landmark trials. Today we have phenotypes, laboratory criteria, and risk stratification. The most important is risk stratification. And with respect to treatment today, we have standard thrombotic regimens, refractory OAPS, and the postpartum state in OAPS. And tomorrow, we'll have biomarkers, precision medicine, and trial gaps. Yesterday, obstetric APS. It evolved from recurrent pregnancy loss mystery to treatable syndrome because most of the conditions with recurrent pregnancy loss meet their Waterloo when it comes to a successful outcome. Obstetric APS plays a very important role in recurrent pregnancy loss. The fact that 70% of them come out with a successful pregnancy with treatment. Now, what is the burden of RPL? It is a source of emotional trauma to the patient with recurrent pregnancy loss, a financial burden on them, and last but not the least, it's a great pressure on the physician and the patient to do something for the couple. In fact, it's absolutely frustrating in the consultation room to meet women with repeated abortion, and I've seen as much as 14 abortions in a woman. What is the definition of antiphospholipid antibody syndrome in the past? APS is an acquired thrombophilic state characterized by the presence of autoantibodies against negatively charged phospholipids and phospholipid binding protein cofactors. The classical clinical presentation is vascular thrombosis and recurrent pregnancy loss, and today I shall be discussing only about the obstetric aspect of recurrent pregnancy loss. The thrombogenicity, the pathogenicity of the thrombogenicity with respect to APL will be one, antiphospholipid antibodies increase platelet aggregation, promoting thrombosis. They inhibit the release of endothelial proteocyclin production. With the result, there's an increased tendency for the platelets to aggregate. And very important, antiphospholipid antibodies inactivate naturally occurring anticoagulants like protein C, protein S, and that is the result ultimately in a hypercoagulable state. So the thrombogenicity of APL is equivalent to a hypercoagulable state. Yesterday, in the timeline of obstetric APS, 1980 was the first time it was recognized as a syndrome by Professor Graham Hughes, the father of the APL story. 1996 to 1997, we had randomized trials ultimately supporting adding heparin to aspirin for OAPS, which came around with a successful pregnancy rate of nearly 70%. 206, we have the modified Sydney criteria, standardized laboratory and clinical classification, and was born the concept of seronegative APS. 2019 to 2020 was the ULAR guidelines and the ACR American College of Rheumatology guidelines. And 2023 non-criteria APL, hydroxychloroquine meta-analysis, and refractory antiphospholipid antibody syndrome emerged. Now, obstetric antiphospholipid antibody syndrome can be divided into primary obstetric OAPS and secondary OAPS. It is secondary OAPS when it occurs secondary to a connective tissue disease, example, classical systemic lupus. Systemic lupus is one disease which is associated with secondary obstetric antiphospholipid syndrome. In fact, the in systemic lupus, they first encountered a false positive VDRL, and ultimately the lupus anticoagulant was discovered, and subsequently Professor Graham Hughes described a syndrome called obstetric antiphospholipid antibody syndrome. It is called primary obstetric antiphospholipid antibody syndrome if it occurs in the absence of a systemic connective tissue disease. The obstetricians see more primary obstetric APS, whereas we rheumatologists see more often secondary OAPS, secondary with lupus. What is the classical clinical presentation or the classical phenotypes of OAPS? You have to ask about the gestational age and the placental mechanism behind every adverse pregnancy outcome. Recurrent pregnancy loss. 3 unexplained consecutive losses before 10 weeks after excluding common causes. The second important one will be fetal death, which explains an unexplained death of a morphologically normal fetus at after 10 weeks. So 10 weeks is the cutoff point. Placental insufficiency resulting in impaired fetal growth retardation, where you'll have abnormal Dopplers, oligohydramnios, placental infarction, and low birth weight. Severe preeclampsia or eclampsia occurring before 34 weeks, that is early onset preeclampsia, especially when requiring delivery before 34 weeks of pregnancy. Maternal thrombosis, DVT, pulmonary embolism, stroke, transient ischemic attack, unusual size thrombosis, catastrophic APS occurring in a pregnant woman, and last but not the least, you have overlap with systemic lupus, acute lupus, acute lupus nephritis, hypertension, and complement abnormalities at risk. So we finished yesterday, and yesterday the most important fact was the birth of the APS syndrome. Number two, the classification into primary APS and secondary APS. And number three, the hypercoagulability associated with obstetric antiphospholipid antibody syndrome. Today, OAPS, clinical recognition of the disease in a different spectrum, laboratories, and risk stratification. Risk stratification is very important when it comes to OAPS. Now, the APL pathogenicity. Initially, it was thrombogenic, mainly in nature, secondary to the presence of antiphospholipid antibodies with a thrombogenic. But now, APS has become an inflammatory autoimmune disease. OAPS is not only a miscarriage disorder, it is a systemic autoimmune prothrombotic and placental inflammatory disease. To repeat again, it is a prothrombotic and a placental inflammatory disease. The disease is mainly in the placenta due to complement activation. Pathogenesis of OAPS involves intricate interactions between autoantibodies, endothelial cells, and the coagulation system. Now, all these days, in the mechanism of APL, we thought it was only causing thrombosis, but there is a mechanism of antiphospholipid antibodies beyond thrombosis. What do they do in the placental level? Number one, they affect trophoblast function. Number two, they inhibit trophoblast invasion. Number three, increased apoptosis of the trophoblast. Number four, defective angiogenesis. Number five, activation of cytokines like tumor necrosis factor alpha, which induce inflammation in the placenta. No wonder in the treatment of refractory antiphospholipid antibody syndrome, anti-TNF biologics like adalimumab have been used. APL also brings about activation of neutrophils in the placenta, causing an inflammatory state. This is very important with respect to APL, activation of the complement, inducing inflammation and resulting in placental injury. There is a passive transfer of APLs across the placenta, resulting in fetal resorption and intrauterine growth retardation. APLs induce decidual inflammation and they also induce platelet activation. So, to sum it up, the battlefield is the placenta, and the very important fact is a process of immunoinflammation thanks to the presence of the antiphospholipid antibodies which react with beta 2 glycoprotein on the placental trophoblast. Coming down to laboratory testing in APL today, depending upon the way of lab detection, antiphospholipid antibodies are christened as anticardiolipin antibody, IgG and IgM, antibody to beta 2 glycoprotein I1, antibody to beta 2 glycoprotein 1, IgG and IgM class, and depend if it is dependent on phospholipid dependent coagulation test, it is called lupus anticoagulant. So to put it in a nutshell, you have anticardiolipin antibody IgG and IgM, you have antibody to beta 2 glycoprotein 1 IgG and IgM, and you have lupus anticoagulant. This is a very important slide. You can ask me a question. You're doing the three tests for antiphospholipid antibodies and what percentage they are positive, which is most common. The most common one is anticardiolipin test antibody, which is positive in 80% of APS patients. Lupus anticoagulant is positive in 30%, and antibody to beta 2 glycoprotein 1 is positive in 20%, and all three are positive only in 25%. This all three is a very dangerous combination in obstetric APS because it has a very high risk of unsuccessful pregnancy. That's very important. When ACL, LA, and antibody to beta 2 glycoprotein are present together at the same time in a patient, you can always tell this patient, you can always take it for granted that pregnancy outcome may be a little underwhelming in these patients and they have to be managed very aggressively. That is why we always tell or perform all the three tests for ACL antibody to beta 2 glycoprotein 1, and lupus anticoagulant because of discordance in the test. And this test has to be repeated at 12 weeks interval. Why should we repeat it at 12 weeks interval? This is to exclude false positive conditions where APL test will be positive, false negative, and lab errors. This is a very important point. Lab errors are quite important. And second thing, standardization of lab test is very important when it comes to detection of lupus anticoagulant, anticardiolipin antibody, and antibody to beta 2 glycoprotein 1. Now we have the modified Sydney Sapporo's criteria, mainly the Sydney criteria here, and the clinical criteria for the diagnosis of OAPS. Pregnancy morbidity. 3 consecutive miscarriages. The SHARE guidelines say 2 consecutive miscarriages less than 10 weeks of gestation. One fetal death which occurs after 10 weeks of gestation with fetal heart documented. One premature birth before 34 weeks gestation due to preeclampsia or placental insufficiency. Especially when it comes to premature birth, it's mainly due to a placental insufficiency, and APS is a notorious cause for placental insufficiency and placental disease and placental dysfunction. Laboratory criteria for OAPS. We'll have increased IgG, IgM, ACL in medium or high titer, a positive test for lupus anticoagulant, positive for antibody to beta 2 glycoprotein 1, IgG and IgM in medium and high titer. One of the three of the above should be positive on 2 or more occasions at 12 weeks apart. So this is the modified Sydney criteria which is available for the diagnosis of obstetric APS. So the diagnosis of OAPS requires one clinical plus one laboratory criteria. This was the criteria which we have been adopting all these years. Now, one important point, practical point I'd like to tell everybody, please do not use the classification criteria for diagnosis. Classification criteria were developed only for research and drug trials, but they were never used for making a diagnosis. If you make it useful for diagnosis, you will not be able to diagnose. One second, please. Sorry. If you use the classification criteria for diagnosis, you will miss out a lot on APS diagnosis. So ultimately, the diagnosis of antiphospholipid antibody syndrome, obstetric antiphospholipid antibody syndrome, is mainly a bedside diagnosis where the clinical criteria are more important than the laboratory criteria, especially the Sydney criteria. In clinical practice, obstetricians should think beyond rigid criteria. That's very, very important. Doing laboratory tests in patients with suspected antiphospholipid antibody syndrome. Doing tests in all people is like giving consent for your marriage without seeing a life partner. What may happen on the day of marriage? It may belong to another species, where the other partner may belong to another species or maybe an intersex, and then your life becomes a horoscope becomes your horoscope. So that is the reason why all people with pregnant women should not be screened for antiphospholipid antibodies. Routine screening for APL in all pregnant women is meaningless unless they have an adverse pregnancy event in the past. But remember, all patients with systemic lupus should have tests done for APL. That's very important. Every SLE patient, if she intends to become pregnant, we should have a preconceptional screening for antiphospholipid antibodies. That's very, very important. Now, what are the indications for APLA testing? 1. Recurrent pregnancy loss. Number 2. Unexplained spontaneous abortions, intrauterine death, or IUGR. Number 3, preeclampsia or eclampsia, moderate to severe before 34 weeks of pregnancy. There is a history of maternal history of vascular thrombosis in the past, histopathological evidence of placental infarction and or decidual inflammation. I'd like to spend a few couple of minutes with respect to the placental biopsy in obstetric antiphospholipid syndrome. When I started talking about obstetric APS, I used to keep on emphasizing placental infarction should be present in the placenta of patients with obstetric APS. But now that has become history because I told you that APS is no more a hypercoagulable state, it is more a systemic autoimmune inflammatory disease of the placenta, and this is placental inflammation is more important in the histopathology than placental infarction. That's very important. And in the other time place situation in which you have to do the test for APL is all patients with systemic lupus. They have to get a screening done for all the APL antibodies. Risk stratification. Yeah, very good. I think the photo itself will show the risk stratification is very important. I need not speak more about the photograph. Risk stratification. Not all APL pregnancies are equal. That's very, very important. It is not a concept of one size fits all. All APL pregnancies are not equal. That's very, very important. Now, what is this risk about which I am talking? Risk stratification is a composite of antibody profile, obstetric history, and maternal comorbidity. To repeat, risk is a composite of antibody profile, obstetric history, and maternal comorbidity. This determines the outcome in obstetric antiphospholipid antibody syndrome. Risk stratification in OAPS. What are the clinical points? It's better you write this off and keep it in your clinical table to tick it off and find out what is the risk stratification. Presence of SLE is bad. History of maternal thrombosis. Previous history of fetal loss. Previous history of severe early preeclamptic toxemia or fetal growth retardation. A history of refractory OAPS, history of hypertension, dyslipidemia, nephritis, and diabetes. So these are all the important clinical points which you should take it into consideration when you have a patient with OAPS in front of your consultation. Do they have any of these things? So the more the number of risk factors, then the more bad outcome you will get it in that pregnancy. So you got to be that such people will have to go high risk category and they require great maternal surveillance. Risk stratification in OAPS laboratory criteria. I told you initially triple positivity, that is lupus anticoagulant positive, anticardiolipin antibody positive, antibody to beta 2 glycoprotein positive. Triple positivity is very dangerous. Double positivity. There can be double positivity for the antiphospholipid antibodies. Lupus anticoagulant as a single positive also is a big risk in OAPS. And high titers of IgG beta 2 glycoprotein 1 and high titers of IgG anticardiolipin antibody are high risk factors. If you take the antiphospholipid antibodies, they are basically immunoglobulins. Immunoglobulins exist as IgG class, IgA class, and IgM class. So you have IgG class is more pathogenic than IgM class when it comes to the antiphospholipid antibodies. So to go through this slide again, we finished the clinical stratification of existing diseases and the past history. The risk stratification in respect to lab, triple positivity, double positivity, LAC as single positive, high titers of IgG beta 2 GPI, high titers of IgG ACL, IG class, IgG class is more pathogenic than IgM class. Why risk stratification in OAPS? Risk stratification in OPS guides the treatment of choice and pregnancy care with respect to antenatal surveillance. The categories are high risk, intermediate risk, and low risk. If anybody wants to know more about these slides, I'll definitely send the article with respect to risk stratification and OAPS. And this is the order of the day when it comes to the management of OAPS. Very important in OAPS, it's a definition, immunoinflammatory autoimmune state. Number two, the placenta is not mainly infarction but residual inflammation. When it comes to the antibodies, they are more pathogenic in terms of causing systemic inflammation, especially activation of the complement pathway. And then you have the risk stratification in terms of clinical factors and laboratory factors. This is just a lab report which shows how lupus anticoagulant is present in the laboratory. It will be lupus anticoagulant detected or lupus anticoagulant not detected. So this patient has got a lupus anticoagulant which is detected, and this is a very important risk factor in the clinical history of antiphospholipid antibody, oxidative antiphospholipid antibody syndrome. This is double positivity. You see the antibody to beta 2 glycoprotein 1, IgM and IgG. IgG is elevated 16.2, and anticardiolipin antibody IgM is elevated. IgG is elevated, I'm sorry. So this is a double positive test of antiphospholipid antibodies in a patient. This means the prognosis may be a little guarded. This is very important report. Three positive, triple positivity, lupus anticoagulant positive, antibody to beta 2 glycoprotein IgG is positive, antibody to beta 2 glycoprotein IgM, anticardiolipin antibody IgG is positive. So three antibodies are positive in a patient simultaneously at one point of time. This means that this patient is a high risk category, and you'll have to probably be very watchful about this pregnancy outcome. This is very important. Now, we have criteria APL antibodies and non-criteria APL antibodies. This is what has come out of research today, that the criteria APL antibodies are lupus anticoagulant, anticardiolipin antibody, and antibody to beta 2 glycoprotein 1. Now, what happened was there were a percentage of patients with antiphospholipid antibody syndrome who were negative for the conventional antiphospholipid antibodies, and then they were coined as seronegative APS. Then they found out when in laboratories that some new antibodies came into being, and these were anti-phosphatidyl serine prothrombin complex, anti-phosphatidyl ethanolamine, antibodies to protein, prothrombin C, protein S, and annexin B, antibodies to vimentin, and you can go on extensively like this. So many other antibodies other than the criteria specific antibodies were detected in the serum of obstetric APS and even primary APS syndrome. So these are called non-criteria APL antibodies. Now what are the tests which are being done in Chennai? The test for anti-phosphatidyl serine prothrombin complex is done in Apollo Hospital. In fact, this test is introduced there, and now we have four tests being performed in the hospital. We have lupus anticoagulant, anticardiolipin antibody, antibody to beta 2 glycoprotein 1, and antiphosphatidylserine serine prothrombin complex being performed at the same time. Four tests are being performed, and this fourth test is very important from the point of view in a patient when the first three tests are negative, the fourth test may be positive. So this is non-criteria APL antibodies. This is important. Non-criteria APL antibodies, other criteria APL antibodies are IgA, ACL, and antibody to beta 2 glycoprotein 1, anti-domain 1 antibodies. Do the test for non-criteria APL antibodies when you suspect seronegative OAPS and when you suspect non-criteria OAPS. I shall discuss to you about seronegative OAPS and non-criteria OAPS. But just remember one thing, you have the conventional laboratory test and then you have the non-criteria APL antibodies. Two types of antibodies exist. Non-criteria OAPS. These non-criteria OAPS actually do not fulfill the Sydney APS criteria. What are all the conditions in which you can make a diagnosis of non-criteria OAPS? You can diagnose one pregnancy loss, two early consecutive pregnancy losses, three non-consecutive pregnancy losses, fourth, late onset preeclampsia after 34 weeks of pregnancy, transient positive lab test for APL, two or more IVF failures, recurrent implantation failure. Antiphospholipid antibodies have been implicated in the pathogenesis of recurrent IVF. That's very, very important. Late onset fetal death after 34 weeks, late onset IUGR after 34 weeks, abruptio placenta, and late preterm birth after 34 weeks. This is a very important slide. You can take a photograph of that. And this is called 9 non-criteria OAPS, which do not fulfill the Sydney APS criteria, and where these are the conditions in which you have to suspect OAPS also, and do the test for non-criteria antiphospholipid antibodies. That's very important. I hope I'm clear. Then you have a third avatar of obstetric antiphospholipid antibody syndrome called a seronegative OAPS syndrome. Does seronegative APS exist? It does exist. What are the features of it? They have the clinical manifestations of obstetric antiphospholipid syndrome, but they do not. They have negative tests in conventional APL testing, negative for lupus anticoagulant, negative for anticardiolipin antibody, and negative for antibody to beta 2 GB1. They fulfill only the clinical Sydney criteria for APS. Repeat testing mandatory before the diagnosis of seronegative OPS, and use your clinical judgment. That's very important. You have to use your clinical judgment when it comes to seronegative OAPS syndrome. Seronegative OAPS syndrome, here you will see definitely classification criteria is not applicable only for the diagnosis, it's applicable only for research. It cannot be applied in clinical practice. Physical judgment and experience is very important when it comes to seronegative OAPS. Labs are not equipped to detect other pathogenic non-criteria APLs. Non-criteria APL antibodies are present in a majority of seronegative patients. Initially, when I infused this concept of seronegative OAPS syndrome in the city, the obstetricians and gynecologists were hostile to it. I actually learned it from Professor Graham Hughes, who is the father of the APS story, and infused it at about the 1990s. People said, no, 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 it doesn't exist. It's only a dustbin diagnosis which you're making. But today, seronegative OAPS syndrome has become an acceptable commodity in the obstetric world, and now we are seeing good number of patients with seronegative OAPS patients. So after having finished yesterday, then I finished today. Then what is the most important point in today which is happening is the treatment today, from preconceptional counseling to postpartum protection. That is the journey which it has gone. So the management of OAPS today, it stands like the Indian team which won the ODI in 2026. It is a multidisciplinary approach with the obstetrician, then the neonatologist, then the rheumatologist, the hematologist, and all of them working together with great coordination to get out a successful pregnancy and also get a healthy fetus. That's very important. Should not forget the child. What are the objectives of managing OAPS? Number one, decrease maternal morbidity and mortality. Number two, decrease fetal morbidity and mortality. Number three, reduce the incidence of preeclamptic toxemia, IUGR, and preterm labor. This is a very important one. Live birth rate is not the only measurable outcome. That's very important. It's no use giving a live child with lot of problems. It includes reduction of APS related conditions, namely preeclamptic toxemia, which earlier was 18%, IUGR 31%, and premature birth, which is about 15%. So all these complications seen in the newborn should be reduced with treatment of APS. That's very important. Now, what are the drugs which are used in the treatment of OAPS? The drugs used in the treatment of OAPS are number one, low dose aspirin, which was the first drug to be used in the management of obstetric antiphospholipid syndrome. Then was born oral anticoagulants and heparin. Then came the wonderful darling of the rheumatologists, namely antimalarials. Steroids have been used for a long period of time. Statins are still in the research. Intravenous immunoglobulin, yes, refractory OAPS, it can be used. Plasmapheresis has become history in the management of OAPS. Then we have biologics, anti-TNF, adalimumab, beta cell depleters, namely belimumab and rituximab, and then you have complement inhibitors, eculizumab. So this is very important with respect to aspirin. Aspirin was actually been recognized as an antiplatelet drug. It inhibits the aggregation of platelets, and it's useful as an anticoagulant. But they have found the actions of aspirin beyond antiplatelet action. Aspirin acts at the placental level. It improves trophoblast invasion of the uterine endometrium. It improves the development of the placenta due to anti-inflammatory effect. It reduces complement activation of the placenta. It modulates trophoblast function. It confers endothelial protection, and it improves placental perfusion. These are the most wonderful actions of aspirin. No wonder it is used in a systemic autoimmune inflammatory state. It results in a hypercoagulable condition. So, actions of aspirin beyond antiplatelet action is very, very important in the treatment of obstetric antiphospholipid antibody syndrome. The second drug which is being used in the treatment of APS, OAPS is heparin. Now we have two avatars of heparin, unfractionated heparin and low molecular weight heparin. At present, low molecular weight heparin has become the drug of choice in the management of OAPS. The low molecular weight heparin, which has withstood the test of time, is enoxaparin, which is a common choice among obstetricians and rheumatologists. Again, coming down to heparin, heparin was initially used as an anticoagulant, but now they found heparin action beyond anticoagulation in OAPS. What are the actions of heparin beyond anticoagulation in OAPS? That is the local mechanism of action of heparin in OAPS. I told you that the placenta is the site where the battle takes place in OAPS, and heparin, God's grace, it acts in the placental level. It blocks activation of complement, has anti-inflammatory properties of preventing leukocyte adhesion, infiltration, and tissue damage. It reduces generation of inflammatory mediators. It facilitates trophoblast invasion of the uterine endometrium. It promotes angiogenesis in the placenta. It confers endothelial protection, reduction of placental injury, inhibits the binding of APL antibodies to trophoblast and endothelial cells, reduce apoptosis of the trophoblast, improves angiogenesis. Wonderful, so many actions of heparin has got on the placenta and local action. And in fact, one can't imagine that it does so much. In addition to being an anticoagulant, hats off to heparin for what it does, and it seems to be a boon to all patients with obstetric APS. It's a wonderful drug. It improved after its usage. The successful outcome of OAPS with respect to pregnancy improved from 40% to 70%. That's a very important improvement with respect to heparin usage in OAPS. Low molecular weight heparin, you have two avatars. One is enoxaparin. We use a prophylactic dosage of 40 milligrams subcutaneous daily, or dalteparin 5,000 units subcutaneous daily. Most of our preferences are for enoxaparin, and even the trials in OAPS, enoxaparin has been the drug of choice. Antimalarials. Yeah, yeah, all of us cannot forget this young boy who's made history and become history. So HCQS is like Suryavamshi today. It's the most important today to tomorrow add-on therapy. It is a wonderful drug in the treatment of obstetric antiphospholipid antibody syndrome, and our chairman, Dr. Kundabi, will agree with it because she's had good experience with hydroxychloroquine also in the management of obstetric APS. So HCQ is the most important day to tomorrow add-on therapy drug in the management of OAPS. This is again, I talked to you about the actions of aspirin locally on the placenta, about the actions of heparin on the placenta. Now we have to talk about hydroxychloroquine mechanism of action. Systemically, it is an anti-aggregant, it is anti-inflammatory, it is immunomodulatory, it is vascular protective, it inhibits binding of APL antibodies to the trophoblast, it reduces complement signaling, it inhibits platelet-induced endothelial activation. So these are all the important actions of hydroxychloroquine. These are all the important actions of hydroxychloroquine. And the other important action of hydroxychloroquine, it is also behaves as an antioxidant in the placenta, and so now hydroxychloroquine is also used in the preconceptional state. That's very important. There are a lot of research papers coming with respect to the preconceptional usage of hydroxychloroquine. Hydroxychloroquine, old wine in a new bottle. What is the evidence for its usage in OAPS? Systematic reviews suggest improved live birth and lower obstetric complications, especially in refractory OAPS, high risk OAPS, and randomized controlled trial evidence is still needed. There is a very large trial going on called the Hibiscus trial with respect to the usage of hydroxychloroquine in OAPS, and the results should be out in a few years. So, hydroxychloroquine is also emerging as a useful drug in APS during the preconceptional period. This is a very important point, and the EU have started using hydroxychloroquine in the preconceptional phase of OAPS. Dosage of hydroxychloroquine. The dosage is 5 mg per kg body weight after food daily. The tablet is available as 200 milligrams and 300 milligrams. 300 milligrams once a day at night or 200 milligrams twice a day is the dosage of hydroxychloroquine. One important fact is before you give hydroxychloroquine to a patient, you should ask whether they have any retinal pathology. If they have retinal pathology, you should not give OAPS, you should not give hydroxychloroquine and OAPS, or if they have any difficulty in vision. That's very, very important because hydroxychloroquine has got an affinity for melanin present in the retina of human beings, and that affinity it can cause vesicous induced retinopathy, which results in defective vision. That's important. What are all the various avatars of OAPS? We have asymptomatic APL positive pregnant women, criteria OAPS, seronegative OAPS, and non criteria OAPS. These are the four avatars of OAPS which can be confronted with in practice. Sorry, excuse me. What about asymptomatic APL positive pregnant women? Therapy is not clearly defined as yet today. These patients have to be under close observation. 50% deliver without drug treatment. But the advisory board of the 10th International Congress on APL advised low dose aspirin alone in these patients. This is important. Now, coming down to OPS management, what prescription do I give in my practice? I start antenatal aspirin 75 milligrams per day plus HCQS 5 milligrams per kg body weight 2 months before they attempt conception. After confirmation of pregnancy, start heparin, preferably low molecular weight heparin, enoxaparin, along with continuation of aspirin 75 milligrams per day, and HCQS when urine test is positive for pregnancy. I don't wait for the ultrasound evidence. The moment the urine test is positive for pregnancy, I start them on a combination of heparin, low dose aspirin, and hydroxychloroquine. Stop the aspirin at 36 weeks and injection enoxaparin 40 milligrams per day will be stopped 12 hours before delivery. Start calcium and vitamin D at conception because heparin can cause osteoporosis and continue it till delivery. Continue low molecular weight heparin for 6 weeks postpartum. Now, this is a very important point that people have found that the postpartum state by itself is a hypercoagulable state, and in the presence of antiphospholipid antibodies, it is adding fuel to fire. So, all patients with OAPS, if you have treated them as OAPS, you have to give them postpartum prophylaxis with low molecular weight heparin prophylactic dosage at least for 6 weeks. This is a must, absolutely essential. Whether they are seropositive APS or whether they are seronegative OAPS, if you treat them as OAPS, the postpartum period, you should not take the risk at all and you should give them low molecular weight heparin prophylactic dosage. That's a very important point. Treatment for OAPS criteria fulfilled. That is, their Sydney criteria positive. That is, clinical criteria is fulfilled. Laboratory criteria for LAC or anticardiolipin antibody or antibody to beta-2 glycoprotein 1 is positive. If it's non-thrombotic OAPS, use prophylactic dosage of low molecular weight heparin. If it is thrombotic OAPS, use therapeutic dosage of low molecular weight heparin. This is very important. No thrombosis, prophylactic dose. The history of thrombosis plus in the past, use therapeutic dosage of low molecular weight heparin. The last few slides, we finished asymptomatic APL positive person, seronegative APS, the conventional OAPS, and now we come down to refractory OPS. Refractory OAPS, the checklist. What is refractory OPS? When the conventional OAPS does not respond to a treatment with low dose aspirin, hydroxychloroquine, and heparin, it becomes refractory OAPS. But before dubbing a person and saying that he's got refractory OPS, check whether your diagnosis of OAPS is correct or wrong. That's important. Number two, the antibody profile persistent. Triple positivity and double positivity, I told you, carries a bad prognosis. Whether it is a double positive or triple positive, you'll have to check. Whether your heparin dosage has been appropriate. Sometimes 40 milligrams of of enoxaparin may not suffice. You may have to increase it to 60 or 80 milligrams per day. Whether you have missed a patient with SLE or lupus nephritis or associated hypertension or associated diabetes. Exclude also chromosomal and anatomic causes, that's important. And this but not the least, poor compliance of patients to treatment. Our patients are more intelligent than all of us. We go to medical college to learn medicine, they go to chat GPT or the internet Google and they become better doctors and gynecologists and obstetricians and rheumatologists than all of us. They stop heparin injection at 3 months. Some people give it alternate days. Some people give it once in 2 weeks. Some people go and give it once a week. And some people give one anytime when they feel like having the heparin. This is not treatment, this is absolute quackery. If you start heparin when the time the lady is pregnant, urine test is positive for pregnancy, you have to continue the prophylactic dose of heparin or therapeutic dose of heparin till she delivers and continue it for 6 weeks postpartum. This is very, very important. So you have to check always the patient compliance because in a busy practice, we may forget to ask whether they are taking the injection or not. And many a time I have been fooled by patients. That's very, very important. So what is refractory OPS? So again, to put it in a nutshell, it is OAPS which is refractory to the conventional treatment with low dose aspirin and heparin. So how do you treat refractory OAPS? This I've learned in my practice in the last 40 years. See, you actually learn by doing mistakes. Increase the aspirin dosage to 150 milligram per day. Or you give a higher dose of low molecular weight heparin. You are giving 40 milligram of enoxaparin, make it 60 milligrams per day or 80 milligrams per day. 80 milligrams per day, I split it into 40 and 40. Add hydroxychloroquine 200 to 400 milligrams per day. Steroids, not very gratifying because of the unwanted side effects of diabetes, hypertension, and cleft palate. Statins are still in the pipeline. We have used provostatin 20 to 40 milligrams per day, which acts more on the placenta. IVIG have been tried, but they are exorbitantly costly. Plasmapheresis not very rewarding, and plasmapheresis is also very costly. So what we have in our hand is increasing the dosage of aspirin, increasing the dosage of low molecular weight heparin, adding hydroxychloroquine 200 to 400 milligrams per day. After coming to all this, I finally learned that in the primary treatment of OAPS also, I start them on aspirin, prophylactic dose of heparin and hydroxychloroquine in the beginning itself, and I find the results have improved when I was not using hydroxychloroquine. Tomorrow, what is the when you look into the crystal ball, what will be the management of OAPS tomorrow when we look into the crystal ball? It will be precision diagnosis, it will be biomarkers, and individualized escalation, artificial intelligence, and machine learning. I doubt I would be there to understand all this in the years to come. Tomorrow, why antibody positivity is not enough. Future care will combine clinical phenotype, antibody profile, and placental biology. Molecular antibodies, you have anti-domain 1, beta-2, AP1, AS antibody to phosphatidylserine prothrombin complex, IgA-APL, epitome-specific signatures. Placental biomarkers, you have PIGDF, complement split products, and markers for endothelial injury. Digital risk models, you have integrated blood pressure, Doppler growth, labs, prior obstetric history, and antibody history. Current criteria are useful but imperfect for non-criteria and refractory disease. So tomorrow's APS clinic will identify inflammatory versus dominant versus thrombotic dominant placental APS phenotypes. And very important is a multidisciplinary approach. So this, if you want any articles on future, I definitely like to send them to you. You can read them, and if you're a male, you can become bald like me. So key takeaways for obstetricians. Why? What should change in tomorrow's morning clinic? Think of APS. Test correctly. Stratify the risk. That's very important. Treat them early and plan postpartum prophylaxis. That's important. So this is a carry home message. Think twice before blaming APS as a culprit for RPL. Exclude other causes. Routine screening during pregnancy for APS is meaningless. OAPS is a treatable cause of RPL and placental insufficiency. OAPS is not only a thrombotic disorder but also autoimmune, systemic, and placental inflammation with complement activation and trophoblast injury. Risk stratification is a must in both clinical and laboratory aspects. Triple positivity, LAC positivity, high titers of antibody to beta-2 glycoprotein IgG or high titers of IgG-ACL are bad prognostic points. Presence of SLE associated with APS is a high risk factor for unfavorable outcome. Optimum treatment is better defined at present. No oral contraceptives in patients with APS. Avoid smoking. APS, culprit or spectator, is dictated by clinical problems and laboratory results. Criteria are mainly useful only to make for research and drug trials. So you should not take the criteria seriously into consideration in the diagnosis of antiphospholipid antibody syndrome. Remember seronegative APS and refractory OAPS. Remember non-criteria APL antibodies. Beware and be aware of refractory OAPS. Remember non-criteria OAPS. HCQ is emerging as a wonderful add-on drug in the management of OAPS. The holistic multidisciplinary approach. Last, do not forget the patient, empathy and tender loving care. Future care will be risk stratified, biomarker driven and multidisciplinary. But last not the least, counseling and love to the couple's well-being. That's very, very important. Tender loving care should always be administered, given to the patient so that they are better off emotionally. This is the last slide. Nearly 2,000 patients with obstetric APS have been managed with successful pregnancy outcome around 70 to 75% in the last 34 years of my practice. And this is what I have left behind on the footprints of the sands of time. I hope I have done a good job with respect to APS. Thank you very much for a patient listening. Thank you.
Thank you, sir, for a excellent and a wonderful talk on this antiphospholipid syndrome of past, present, and the future. I think we have got few questions over here. Am I wrong in starting HCQ after the patient becomes pregnant in a case of bad obstetric history?
Not at all. You're not wrong. Before, we people used to start after pregnancy, but now we have started preconceptionally also. You can start HCQS 2 months before they attempt conception. But nothing wrong in starting it. There is no trial starting it between starting before and starting after. But it's better to start it early because the wonderful two articles have come recently in 2026 with respect to the usage of HCQS preconceptionally in OAPS. You can start them even after the patient becomes pregnant. One important point, as long as we start HCQS, we are doing wrong. HCQS has to be given to patients with OAPS.
So should we test get an ophthal opinion and an ECG as well before we start HCQ?
No need to do an ECG, because I know it shortens QT interval, but it doesn't do that in the dosage we give. So it's it's not necessary, and not necessary for an ophthalmic screening. I don't screen them because I give it only for a period of 9 months. Only when you go to 1 year, you have to do it. But sometimes when I see finicky patients who are, who can be medically ill in their aspect, I get it done. But you are not doing wrong by not doing a test ophthalmic consultation at all.
So
But I
there's
ask
another
them,
question. Yes, sir.
but I ask them for a history of visual problems and retinal problems. That I ask them. And if they are a diabetic, I always get test for diabetic retinopathy and also get an ophthalmic opinion.
So another question over here in the spectrum of APS, why some patients evolve into vascular thrombosis APS and some evolve into obstetric APS. So what is a single and significance of single positive APL pregnant woman? Do we have to repeat the APL test repeatedly in OAPS patients during pregnancy for monitoring therapy? When are steroids indicated in patients with OAPS?
Kundevi, can we go one question by one question?
Yes, sir. There are few patients who's got vascular thrombotic APS and some evolve into obstetric APS.
That's a very brilliant question. See, if you take the spectrum of OAPS, the common denominator is the presence of antiphospholipid antibodies. How is it one group develop vascular thrombosis, the other group develops echo. The other group, there's an echo here. One group evolves into vascular thrombosis, the other group evolves into obstetric APS. This is all because of the presence of beta 2 glycoprotein present in the trophoblast of the placenta. Antiphospholipid antibodies definitely combined with beta 2 glycoprotein in the placenta. So whenever the lady is pregnant and she's got beta 2 glycoprotein 1 present in the placental trophoblast, they evolve into obstetric APS. If they are not pregnant, then beta 2 glycoprotein is not available for binding, so it doesn't result in an obstetric APS, it results in a vascular APS. That is the explanation which has been given, and rightfully so, it is quite clear and correct.
So what is the significance of single positive APL
Yeah,
in pregnant women?
yeah, you have to look at it as a single positive APL in a very different way. You can't dismiss it off like that because single positive APL, when it is there, you'll have to ask them a history of any vascular thrombosis earlier in the past, whether she's got SLE, that's very important. And number two, whether the single positive APL is lupus anticoagulant or high titer ACL or high titer antibody to beta 2 glycoprotein 1, which are prognostically high risk factors. That's a very important one. What APS is positive, we should take it into consideration. That's number one. So, single positive APL test cannot be ignored. That's important.
Do we have to repeat the APL test repeatedly in OAPS patients during pregnancy for monitoring therapy?
There is no need to repeat it. It's only financial expenditure because we are not going to treat it. It's not like blood sugar, which we estimate. So, no need to monitor the APLA levels at all. Once they are the OAPS lab test positive, they are positive. That is enough. No need to
Is it
repeat.
advisable to repeat these APL testing in pregnancy, sir?
There is no need to repeat it, ma. Once you have started treatment, there's no need to repeat it at all. It doesn't influence.
When are steroids indicated in patients with OAPS?
To be very frank, after extensive reading and good experience also, I give steroid only when APS patients have associated SLE with active disease. Otherwise, I don't give steroids at all. Because steroids have definitely side effects, and what the dosage we give is about 10 milligrams or 5 milligrams, which is a minuscule dose. So steroids now are actually gone out of reputation. Steroids are not useful in patients with APS, especially so in refractory OAPS.
So what is the role of DOACS in OAPS?
What is the role of TO?
Capital D, capital O, capital
Ah,
A, CS.
directly acting oral
Yeah.
anticoagulants. There is no role for directly acting oral anticoagulants in the management of obstetric APS. You should not give, they are useless. They are not useful at all. So that's not used at all. We use only the vitamin K antagonists like warfarin. Oral anticoagulants, we use warfarin. But only important point, warfarin is teratogenic between the 6th to 12th week of pregnancy. So whenever the lady who's on warfarin becomes pregnant, we immediately change into low molecular weight heparin. But oral anticoagulants, vitamin K oral anticoagulants, namely warfarin, is not contraindicated in breastfeeding mothers. That's a very important point.
What is the incidence of vascular thrombosis APS in the newborns born to OAPS mothers?
That's an interesting question. If you take obstetric APS is a different entity compared to vascular thrombosis OAPS. But in a follow-up of patients with obstetric APS, they found 10% of patients develop vascular thrombosis over a span of 10 years. That's very important. 10% in 10 years develop vascular thrombosis. So who are the people who have to be given low dose aspirin in in obstetric APS after they deliver? Again, history of previous thrombosis, you'll have to give low dose aspirin. Otherwise, we just follow these patients.
So what is your take on prophylactic administration of low-dose aspirin and execute during preconception in OAPS patients, mothers?
My view is after reading these three articles, I've started using them in the preconceptional phase of OAPS. Low dose aspirin as well as hydroxychloroquine I use.
Okay.
I start them 2 months before they attempt conception. That is for priming the uterus for pregnancy.
So, like as a gynecologist, I think there's another question also here. Some patients with OAPS, a few weeks after testing, after starting this low motor heparin, they develop spotting. And ultrasound showed a subchorionic collection hematoma. So, what do we do? Should we stop the aspirin and the heparin for some time because we are worried about the bleeding, we are worried about the subchorionic collection? It's like a cat
Very
on the
good.
wall situation.
Yeah, very good. You have given the answer itself, ma. I withhold it for a week. I withhold low dose aspirin and heparin for a week, and we do an ultrasound again after 1 week. If it is reduced, I introduce low dose. I introduced heparin. Then after the next week, I introduce low dose aspirin again.
So, what is the prevalence of OAPS in general population? And what
OAPS
is the
incidence of general population is around 5%.
and what about in RPL?
In RPL, it is about 10%. That's why 10% of patients we miss. Because OAPS is a treatable cause of pregnancy. 10% of patients with RPL may be OAPS.
And what is the percentage of again refractive OAPS in OAPS? Refractive OAPS
To
percentage.
simply, to simply put it, regard, if you take 100 people with obstetric antiphospholipid antibody syndrome and treat them with low dose aspirin and heparin, the successful pregnancy is 70 to 80%. The remaining percentage becomes refractory. So 20 to 30 patients of OAPS are refractory antiphospholipid antibody syndrome. But that percentage has come down thanks to a wonderful adjunct drug, hydroxychloroquine. Now the rate has even reached 90% in some trials.
So this is again for fertility. So what is the current opinion on performing all these tests for APL in all women being investigated for primary fertility, and what about in men as well?
It is meaningless to do tests for APLA in patients with primary infertility, both female and male. That's important. It is still under a cloud, but most of the studies have shown that it is no use doing it. That's number one. Number two, male fertility, infertility. They have reported some patients with testicular vein thrombosis and testicular artery thrombosis with testicular infarction, which has been the cause for male fertility. In females, they have not found APLA as being causative and pathogenic for female infertility. So the answer is no necessity to do the test for APLA in male infertility and female infertility.
So when to stop HCQs in Napier syndrome during pregnancy?
Once they deliver, you can stop it. Only thing, if they have SLE, you have to continue the HCQs after delivery.
So you were talking about the seronegative plus, and you said that we may have to do a phosphatidylserine serum test. Even if that is negative, but clinically the patients are showing pregnancy loss. So what do we do in such patients?
I treat them as seronegative APS. See, one important point, Dr. Kundavi. Initially, I was frightened to treat them as seronegative APS. But after treating patients without any hesitation, I've realized that we are doing them a lot of good and there's a great increase in successful outcome. Because antiphosphatidylserine prothrombin complex is one of the non-criteria, is only one of the non-criteria APL antibodies. Our lab tests now, they are trying to detect antibodies to beta-2 glycoprotein domain 1. If that test comes, it will be better for us also. So slowly more tests are being added in the armamentarium to detect non-conventional antiphospholipid antibodies.
There are a lot of medicines like thymosin, tacrolimus, and anti-tumor necrosis factors and everything. So what do you think when all these tests are negative, but still patient is, though we call it a seronegative, would you like to add these drugs as well?
Thymosin and tacrolimus are not being used in the treatment of OAPS. Biologics have been used in the treatment of OAPS. In fact, I have used anti-TNF, anti-biologics, namely adalimumab, in the treatment of refractory OAPS. I used it for 10 patients and nearly about 5 patients delivered. I totally gave it for 50 patients. In the 50 patients, the success was only 5 people compared to the 50 I had taken. 5 people only came out successful. But still in their infancy, so no use of anti-TNF factors. There is one drug which is very useful in the treatment of refractory OAPS. It is a complement inhibitor called as eculizumab, but it's very costly. It costs 5 lakhs to 6 lakhs per injection. So once it becomes cheap, definitely we'll be able to use it because it's a very, very useful drug to treat refractory OAPS, because basically OAPS is a complement mediated disease. In fact, now they are saying low complement level also shows the disease is active. So once eculizumab becomes available in the Indian market and becomes quite cheap, we can use it in the treatment of refractory OAPS. It's a wonderful drug.
So normally when we do any testing like IgG and IgM, we always think IgG is a past infection and IgM probably is an acute. Whereas here you said that IgM positive is more prominent, that has to be taken into consideration when compared to IgM. Why is that, sir?
I think உனக்கு 100 பொன் காசு கொடுக்கணும்னு நினைக்கிறேன் for questioning. திருவிளையாடல் மாதிரி. Now basically, sorry for that. See, basically, if it comes to infection, the first class of antibody to be synthesized in response is IgM. Then when it comes to memory, it becomes IgG class. That is infection. This is non-infective pathology. This is an immunoinflammatory problem. So in an immunoinflammatory problem, they have found IgG class to be more toxic than IgM. That is why the difference here. In infection, it is IgM which is you have to take it seriously. In immunoinflammatory, you take the IgG class very seriously. That is the answer.
So can you assure all of us that yes, you've identified, and by starting this low dose aspirin preconception and HCQs and giving heparin, that we could save that pregnancy?
Nearly to an extent of 90%. Now the studies, some studies have shown 90%. So around 80% success you can tell. 20% they fall into the refractory OAPS group. So if eculizumab comes to the market, then the success rate may go up to 90%.
So whenever patients take a low maltodextrin, we could see the skin discoloration. So how do we avoid and how do we
Ah,
tell them to be taken, how to be
that's a
taken?
very relevant practical question. Very relevant practical. In fact, people call me even at midnight and say that there is a blackish discoloration and the site of injection. I think it's a side effect. It is due to bleeding. You are giving me an injection which can cause bleeding. That is mainly due to faulty technique. The injection should be given perpendicular to the arm or perpendicular to the abdomen or perpendicular to the thigh. At right angle, they should put the needle. When you give it at a slant, what will happen is there's a little amount of oozing of the injection in the subcutaneous plane or just beneath the skin, and that leads to ecchymiosis. It is a faulty injection technique. Faulty injection technique is 100% responsible for ecchymiosis at the site of injection. Number one. Number two, they should not massage that area very forcefully. Just a thin, just a thin, not a light scratch. What I meant to say, a light touch over the area of injection can be given. You should not massage. No application of ice. These three things have to be given to the patient. Sometimes after injection, they vigorously massage that area, so that leads to tachymeiosis also.
So being a senior most rheumatologist and every gynecologist is happy to refer a patient to you. Can you have a control over the drug committee people to reduce the cost of low molecular heparin? Because I think when it goes to patients comes about 300 plus or something because they're going to take it till term and post delivery for 6 weeks. Your take home message for us, sir.
Yeah, I've been pleading to the companies. I've not gone to the drug control, but I've been pleading to companies to reduce the price. And I don't know whether I should tell this in this meeting, but I'll definitely tell you one important thing which Cipla has come. Initially, I was using enoxaparin, and they used to give a discount of about 10% on low molecular weight heparin, the original brand Rexane. But when I spoke to Cipla people, I can really admire them for their generosity. They reduced it by 50%. Now a 400 rupees injection is available for 200 rupees.
I think that's a message to all the gynecologists who have attended this meeting.
Yeah, that's no, I'm really grateful to them. I do not know how else to thank these people. I told them, please do something for my patients. I still remember what Mother Teresa did once in Calcutta when she was asking for her orphanage. She put her right hand to wealthy people and asked, give something for my children. They spat on the right hand. Then after they spat at the right hand, she showed the left hand and said, now that you have given me this, I thank you for what you have given me. But give me now again something for my children. So one important point is we also as doctors beg to companies to reduce the price, and this company, the especially the critical care team, they said immediately they reduced. Spontaneously on the spot, they said, I'll reduce 50% of the price and give it to them. So I give all the patients the telephone number of the Cipla representative, Mr. Rajesh, and he immediately supplies the medicine at 50% reduction. And thank you very much, Cipla, for doing this. I think this is a unique thing which you are doing for the human world, especially with women with recurrent pregnancy loss. The financial stress they go through is in fact significant and very upsetting, to be frank, emotionally.
So that's the reason we give them alternate days, weekly twice, or even you even tell them, sometimes these patients miss those injections because of the cost. And I think that's a wonderful message for all of us that the CIPLA has come down in the cost. I think most of us would benefit by using the drug actually. Any
I'm
more
not telling
questions?
this because this meeting has been sponsored by them, but that is the truth. I have to be truthful in what I tell about people.
It's only in Apollo they have this package of all this phosphatidylserine or something, or anywhere else also these people are doing, sir?
Nowhere else it's doing because when I'm there, I introduced it. But that's a very useful package because 4 tests are given economically for a price of about 16,000 rupees. But antiphosphatidylserine, that kit for it is quite costly, ma. It's
Okay,
imported
sir.
from US. But after doing it, my diagnosis of seronegative APS has increased, evidence-wise, laboratory-wise.
Okay. I think with your advice, we have been using HCQ left and right for all our patients with RPL and as well as RIF. I think we have published paper also on that.
Ah,
And I think it was a wonderful drug. Only one patient had developed some skin rashes or something. Then again, she conceived and she's delivered too. So
yeah.
I think thank you so much, sir. Any questions from the audience, Mr. Rajesh?
The other important point about HCQS, prolonged usage, it can cause hyperpigmentation and blackening of the skin.
Yes,
That is
sir. That
cosmetically.
had. Yes.
So I tell these people jokingly, for a child, it's not bad, but it's worth becoming dark, no problem at all. The child will expect a little dark complexion mother.
Rajesh, any other questions? Because I'm not able to see any questions from there.
No, ma'am. No, ma'am. That's it.
It has been clarified, ma'am. Thank you very much, ma'am, for the clarification you have made. And
Dr.
Sam also.
Ramakrishnan, sir, that was a wonderful meeting. I think the people who did not attend is a big loss, but I'm sure these people will give us the recorded link so that we can post it in all other groups with your permission.
Yes, ma'am.
They are already putting it in YouTube.
Okay. Thank you. Thank you so much.
Thank you, Dr. Kundavi. Thank you,
Thank
Sipla,
you,
for
sir,
giving
for
me
the
the opportunity.
wonderful Sunday evening, a well spent Sunday evening. Hats off to you, sir. Yes, sir.
Thank you, ma'am. I've been preparing for nearly 5 weeks with this, burning the midnight oil, getting up at 4 o'clock and reading. So I must thank my wife for giving me an opportunity to read.
Thank you, sir. Thank you.
Thank you, ma'am.
You're a
Thank you,
wonderful
ma'am.
person.
Thank
Yes,
you,
sir.
sir, for this wonderful event, sir. Thank you, sir.
So,
And
Thank you.
Sipla, thank you so much because sir has said that you have come down in the cost. I'm sure the entire obstetric team would really benefit by using your drug. Thank you so much.
Thank you. Thank you for your compliment. Thank you very much, ma'am, for the trust and quality, ma'am. We ensure the quality, ma'am. And we want the patient to be served, ma'am. That's why Cipla is saying caring for life. We want to caring for life and we want to give a good medicine in a low cost.
Thank you.
Thank you, ma'am. Thank you, Ramsha.
Thank you, Sipla.
thank you,
Thank you,
sir.
sir.
Thank you.
Thank you.
Thank you, ma'am.
All right. So as we come at the end of the today's webinar, so on behalf of Cipla Critical Care, I would like to express my sincere gratitude to our esteemed speaker, Dr. Ramakrishnan, for sharing his valuable expertise and practical insights on antiphospholipid antibody syndrome. Also, our heartfelt thanks goes to our respectable moderator, Dr. Kundvi Shankar, for expertly guiding today's session and facilitating the insightful discussion. Thank you so much, ma'am. And also, most importantly, we thank all the doctors who joins today's session. We hope today's discussion provide you valuable clinical takeaways that you can apply to your practice. Thank you once again for contributing support and association with CIPLA. Thank you. Have a nice evening. Thank you, ma'am. Thank you, sir.
Thank you.
Thank you. Good night.
Good night.
Can we leave?
Yes, ma'am.
Yeah. Thanks.
Yeah.
Yes, ma'am.
Thank you, sir. Thank you, Ramakrishnan, sir.